This is Dr. Randy Fugit, professor for PRDO 7720, Upper GI Disorders. And after 20 years of teaching this section, Dr. Reynolds approached me and said we should probably start to do something a little bit different. And with that, he suggested that I actually go over this individual case and give you kind of an idea of how I would manage this patient in clinic had he been one of mine. So with that, let's go ahead and get started over the next 5 minutes. I'll try to give you some tips and tricks of the importance of managing these types of patients. So I'm going to go ahead and start off with reviewing his chief complaint, past medical history, and so forth. So Bernie Avalanche, yes, I'm a hockey fan, is here today for follow-up regarding his management of gastroesophageal reflux disease. He describes worsening recurrent symptoms since his last appointment. And when we look back at his history of present illness, what you're going to find is that Mr. Avalanche is a 59-year-old gentleman, unfortunately morbidly obese, who presents to clinic today with worsening symptoms of his GERD. He describes a burning sensation in his chest and belching that is associated with a significant acid taste in the back of his mouth. And most of you will recognize these are very common symptoms associated with reflux disease. Continuing, he states that it has worsened significantly since his last appointment when he saw his primary care provider, when the dosage of his lansoprazole was actually decreased from 30 milligrams once daily, that was working pretty well for him, it seems, and unfortunately was put on ranitidine 150 twice daily. Now, this is a very common strategy that a lot of providers do. We're trying to step patients off of PPIs, especially when we start considering some of the adverse events associated with this type of therapy. He also states that his symptoms have been occurring now almost daily. It's actually keeping him up at night, and he has now been on anti-reflux therapy for the past 2 years. Looking back, we can see that he has developed LA Class C erosive esophagitis, and obviously that's pretty significant disease. It's one of our more worsening and more worrisome, if you will, types of erosive esophagitis. He was appropriately treated with 8 weeks of lansoprazole at high dose therapy, that means BID, for 8 weeks, and then started on maintenance therapy with lansoprazole 30 milligrams thereafter, which is a very common approach after we've achieved healing of erosive esophagitis. He then had no symptoms whatsoever, as you can see here, and he was stepped down to ranitidine last month. It was not necessarily his provider's decision to reduce the ranitidine at this point, but more so because he was concerned after watching the news and noticed that there was a risk of developing Alzheimer's disease associated with long-term proton pump inhibitor therapy. Past medical and surgical history, he has hypertension, type 2 diabetes, hyperlipidemia, the gastroesophageal reflux disease that we've already mentioned, as well as depression. His current medications include lisinopril 20 milligrams daily, atorvastatin 40 daily, metformin 500 milligrams twice daily with meals, disipramine 25 milligrams at bedtime, takes an enteric-coated aspirin daily, artificial tears 1 to 2 drops with both eyes 4 times daily as needed for ocular dryness, and it was impressive how some of you actually identified that it was likely the disipramine that may be causing his ocular dryness, so kudos to you. And then he takes a little bit of Tylenol as needed for some joint pain that he once in a while experiences. He has penicillin as an allergy. Family history is non-contributory. His social history, we do know that he is a non-smoker, which is wonderful, and does have an occasional drink once in a while. Physical exam, as you can tell, is pretty much non-contributory, and his vitals remain fairly normal for a patient of his age and type. Looking real briefly, I just want to go over the most pertinent labs that you obviously, the majority of you have identified as hemoglobin and hematocrit are slightly decreased, if you will, demonstrating a little bit of anemia in our patient. All other labs are within normal limits. So what I like to do is when seeing a patient in clinic, especially who presents this way, obviously, as we've been working on throughout the entire section, is developing the problem list for a patient. Now, my problem list may differ a little bit from the ones that you've developed, but obviously some of these are some of the core issues that I feel that we should be addressing at this clinic appointment for this patient. So if we look at a very specific focused problem list for him, that is issues related only with his gastroesophageal reflux disease, I've come up with obviously uncontrolled Gerd. This is his biggest problem. The erosive esophagitis that he's now developed, unfortunately, again, this time a very mild form of it with LA grade A. I like to consider quality of life in all patients with reflux disease. I'll explain that in a few moments. And then finally, we need to counsel this patient regarding his reluctance, if you will, to taking a proton pump inhibitor and discuss the issues of risk versus benefit in an individual who unfortunately has discovered that there may be a potential adverse event awaiting him if he continues to take this medication. So with that said, let's start our assessment and plan with his uncontrolled GERD. I think a lot of you have identified some of the more significant risk factors he had. I believe one of the major ones he has is actually his obesity. So in our assessment, obviously morbidly obese, how old did I say he was? 59-year-old gentleman. This is something we obviously need to consider when we start developing a plan for our patient, and we'll put that together here in a few moments. Other issues I had, and one that a few of you missed, was actually diabetes in our gentleman. Remember, diabetes unfortunately can lead to gastroparesis in these patients and lead to more of a gastroparesis-induced reflux due to significant reduction in peristalsis of the GI tract leading to reflux disease. So this is a very important issue to obviously consider in our patient. His alcohol use obviously may be contributing to some of his symptoms. And then finally, for drugs, I have aspirin and desipramine. Now, aspirin, I'm really not going to change in this gentleman's therapy, nor am I going to change the desipramine, but realizing that aspirin is more of a caustic substance in the esophagus rather than actually setting up per se true reflux disease. However, the desipramine does unfortunately affect the lower esophageal sphincter that may be promoting reflux disease. So obviously he has no real significant warning signs. So if considering a plan for this individual for his uncontrolled GERD, obviously all of you got this across the board, and that is the issue of lifestyle modifications. I'm not going to spend a lot of time on this, but you can review it in the chapter. But obviously losing weight is going to be one of his most significant things, decreasing large meals before bedtime, elevating the head of the bed, trying to get him off some of his ETOH if we can, or alcohol if we can. So we have some options that we can do for his uncontrolled GERD. But unfortunately, it's the next issue that I want to talk about, and that's his erosive esophagitis. And a lot of you correctly identified that patients with this severe of disease likely should not be stepped down off of a proton pump inhibitor, and that was one of the goals of this discussion. And you all pretty much hit it on the head. I absolutely would not have reduced him down to ranitidine, and unfortunately we see what happens. So with that said, obviously when we start developing the plan for this gentleman, and there are virtually lots of different plans that I accepted. As long as you put him back on his PPI, I was fine with that. I do agree that I would probably start him on high dose therapy again to allow for healing for 8 weeks. And if you chose lansoprazole 30 milligrams twice daily, you chose omeprazole, pantoprazole, as long as you chose a pretty equivalent dose, I was fine with it. Even if you chose dexlansoprazole, 60 milligrams once daily, a very effective agent, quite expensive, but still an option. And then obviously would step him down to some appropriate therapy. In my case, I thought the 30 milligrams lansoprazole was doing just fine. Some of you suggested 15 milligrams. Let's see how it does. I didn't take off any points if you selected either of these, but you demonstrated an appropriate step down for our patient. Looking at his drugs. Now, I would not stop either the aspirin or desipramine immediately at this point. He was well controlled on these agents and probably will continue to do so. He has a lot of risk factors for cardiovascular disease, but I understand a lot of you made the point that primary prevention is probably not evidence-based at this time. And I concur with that. If you wanted to stop it, that's fine based on that reason, but not because of his reflux disease. However, he is on an enteric-coated aspirin, which hopefully will not cause too much significant erosive issues within his esophagus. As far as a lot of you wanted to suggest changing the desipramine right away to a SSRI, not a bad idea. But one of the things that you really need to consider in this patient is obviously that our patient likely is on this for a very different reason. This is second line therapy of depression, so there may be some other reason why his mental health provider put him on this. I would not just stop it immediately. Uh, Finally, but we could obviously talk to them, counsel him regarding his issue or quality of life. And this is very important to reflux disease patients. Quality of life is very important, and a lot of our patients suffer significantly. Quality of life has been described somewhere between heart failure and depression for patients with severe Gerd. So obviously addressing this and getting his symptoms under control, which is one of the reasons why I liked going up to the higher dose therapy early on, try to get his symptoms under control as quickly as possible and manage this. And finally, we need to counsel him regarding his reluctance to taking a proton pump inhibitor. He has some pretty significant issues here. He's older. He's worried about developing dementia. However, all of you who did discuss this, and I'm very proud of those of you who were able to pick this up and put it into your plan, because if he doesn't take the PPI, nothing is going to work for this individual, and we're just going to get into more significant erosive disease. So we do need to address his aversion to PPIs. A lot of you discussed that we obviously have 4 trials right now looking at the issue associated with dementia in patients on long-term PPI therapy. And a lot of you correctly identified some of the issues with the 2 earlier trials that actually showed that there was a possible association. Now, with all of these trials, I do want to point out that they are all retrospective in nature, which means that they can demonstrate association, but not causality. And we've had a lot of issues over the years with proton pump inhibitors being blamed for all kinds of problems. And when we finally do the randomized controlled trials, we see that some of them don't necessarily fall out as we thought they would and may not be at risk. I think the clopidogrel issue was with proton pump inhibitors associated with increased cardiovascular events after PCI, probably one of our most important issues that we've learned from that randomized trials cannot be the most appropriate. So obviously counseling him on these issues and allowing him to make the decision and weighing risk versus benefit is probably one of the biggest areas. So with that, that is kind of my way that I approach this case. I would love to hear any comments from you, things I may have missed and so forth. I was trying to be as quick as possible discussing this with you, but please let me know if I've missed something. Can't get it all, but it gives you a good idea of what I'm thinking of in our patient. And oh, the one last thing I just realized I forgot to mention was his type 2 diabetes. His diabetes appears well controlled at this time. We didn't have a hemoglobin A1C, so I would not be too concerned with this issue. It appears to be well controlled, but obviously we'd follow up the patient and make sure he does okay. Well, let me finish by stating I cannot thank you enough for being part of this class. As always, I learn as much from you as you do, hopefully, from me, and look forward to hopefully practicing with you in the future. Good luck with the rest of the course, and please take care.